Hey y'all, I'm going to briefly go over addiction pharmacotherapy. These are my PowerPoints out of a different from a different book that I taught from, and they sort of broke this out into a different chapter, and I appreciate that. So I'm adding that to the relapse prevention chapter, and you'll find out you'll see sort of the commonalities as we go through and why I decided to put this in with relapse prevention. So addiction pharmacotherapy is essentially medication used to treat addictive use disorder symptomatology. So that's cravings and some of the symptoms that may be associated with withdrawal. Some of them can be aversion medication. So you take this medication and for example, this is used with alcohol. If you take this medication, you would get sick if you drink alcohol. So there's a couple different classifications and categories, and I give you a handout and then this PowerPoint, and then I think there's so there's some stuff for you guys to reference for addiction pharmacotherapy. Okay, so I think the reason why I wanted to make sure that we touched on this is because we have you see this last bullet point, we have an ethical mandate to offer evidence-based treatments to clients. And what we know is that medicated assisted treatment works and it helps folks. And so regardless of your stance or your position on medicated assisted treatment, as counselors, we have to sort of bracket our opinions and maybe what we've heard and some of the myths and make sure that we offer clients all that is out there for them. And the reason why these myths exist and somewhat perpetuated by AA 12-step movement is that they think that it is, or they thought, I think that that's changing, and I'm happy to hear that that's changing in the AA 12-step movement. But the thought is that you are replacing one substance with another substance. So replacing, let's just say, replacing an opiate with an opiate. That's not totally true, but that's sort of the thought. Or that it's a crutch. So rather than just quitting cold turkey or quitting with the help of AA and 12-step approaches or a treatment approach, that you're using the medication as a crutch, and you're not really addressing what needs to be addressed in order to stop using. And I have, as we go through this, you'll see that also is not necessarily true and not founded in the evidence that suggests that medication is actually really helpful. So these are some key terms here: agonist, antagonist, neurotransmitters. None of these you're really going to need to know. In the medications used to treat opioid dependence, some are agonists, some are antagonists, some are partial agonists, but you do need to know what the different medications are called, and you need to know the differences between them. I'm going to sort of skip through some of these that we don't really need to talk about in this brief video. What you do need to know is that depending upon your client's race and gender, that psychopharmacotherapy for addiction treatment needs to be considered. So race and gender can affect the outcome of the medication, and that's important. As with we've got our three sort of main neurotransmitters here that are in play when we talk about addictive use disorder: serotonin, dopamine, norepinephrine. Those are what the medications are sort of acting upon and attempt to change, affect, or block, or mimic. Let's see. Half-life. I'm going to post a video about half-life that I want you guys to watch, but and it's a short video, but essentially half-life is the amount of time that it takes a medication to leave your system. And so half-life isn't half, in this amount of time, half the medication is out of your system, and then in that same similar amount of time, another half of that medication is. That's not how it is. It's half of the half has left your body. This will make sense when I post the video. You really only need to know this if you're talking to maybe a psychiatrist and consulting with one of your clients, but know that when half of the medication leaves the client's body, it doesn't mean that in the same amount of time the rest of that half will leave their system. So make sure you watch the video on that. So this just goes into craving for alcohol. We're going to talk about some drugs for alcohol abuse and use, and one of those addresses craving. And so we're going to jump into that in just a second. But this slide really talks about, I don't know if you can see that. I think I kind of messed up where this goes. But this slide really talks about your role. And so why do you have a role? Why do you need to know about addiction pharmacotherapy or medicaid-assisted treatment? Well, that first bullet point says it pretty clearly. You have more contact with your client than the psychiatrist or the prescribing physicians. You will see your client on average about once. The psychiatrists will not. They will see them once a month if your client is lucky, and usually for about a 15-minute med check. And so you have more eyes, or you have the ability to have more sort of eyesight and information on your client because you see them more, you talk to them more, you can ask them on a more regular and more frequent basis, what is this medication doing for you? How do you feel? What are the effects? You can sort of document those changes, good or bad, in a more consistent manner than the psychiatrist can or the prescribing physician. In theory, because you are a counselor and because we place so much emphasis on the relationship, my hope is that you have a strong working alliance with your clients, so they trust you, so they can talk to you about some of the things that they like or they don't like about this medication, their fears and their worries about being on medication, because you have this alliance, because you have this relationship. And one part of your role is going to be education, and that's why I added this little section here, obviously, because you need to know about Medicaid-assisted treatment. You need to know what it's for and how it works, and you need to know not just what you hear or myths or information that may even challenge your bias, your own bias. I worked at a treatment center and this treatment center strongly utilized AA 12-step approach and the use of Suboxone, which we'll talk about in just a minute, which is used to treat opioid disorder, for opioids, both heroin and synthetic pills. They absolutely, no one could be on it, and it was thought that you were just replacing one medication for another. And so they did not utilize that medication for their clients, and no one could be admitted to the program if they were on that medication. Same thing goes with methadone or maybe naltrexone or something like that. So that's why I think it's important for you to be educated on this. And so it's also important for you to promote them sort of sticking with the medication. Some of these medications have a little bit, take a little bit of time to get used to, and knowing this, you can tell your client, I promise maybe this nauseating feeling will pass, or this isn't right, let's talk about changing, let's talk to your psychiatrist about changing some of these medications. But really, really sort of helping them be compliant with medication and talking to them about sort of the, what to expect. So that's your role. So again, like I talked about with alcohol, there are 3 types of treatment. One that's aversion, one that addresses withdrawal, and one that addresses craving. So you have the aversion, alcohol withdrawal, and anti-craving right there. And there's a ton. You see there's 150 medications that have used to treat alcohol. The aversion meds aren't used all that. They're still used, but I think people tend to find that it's really uncomfortable. And so they go with one of the other medications, but they are out there. So the aversion, first line, when you see at the top of these slides, first line versus second line, that just means the medications that the psychiatrist is going to prescribe first, so prior to all these other ones. So like I said, you develop an aversion. So Antabuse is the name of the drug, and if you take this drug and then you drink alcohol, you literally get sick. You get nauseous, you throw up. Your stomach is upset. It's really unpleasant. So that's why it's called an aversion treatment for alcohol. And so that would be sort of the first thing to try. And if the individual can handle that or stick with that, then they wouldn't go to a second line of drug, but usually people don't particularly care for that. Regarding alcohol withdrawal, so some of them can be Valium or Ativan, or any other benzodiazepine. Now, this is not given to clients to use on a regular basis. This is used when a client enters into a detox center. So when they enter a detox center, detox from alcohol can be particularly deadly if not titrated and medicated appropriately. They can die. They have seizures, and it can be really bad. So these medications, these benzos, are used, as you can see, to increase sedation, so that an individual can withdraw without having those severe side effects related to withdrawal. So this is not one that they're going to be prescribed for a very long time, and they're only going to be prescribed these medications while they're under the care in a detox facility of someone who can monitor them. So withdrawal second line treatment. So they can take these after they leave, and so this really addresses cravings. This addresses and can also mitigate some withdrawal issues, but can also, as you see, address the craving aspect. So it works on an aspect of your brain that sort of dulls the strong craving that one may have with alcohol. And another set of anti-craving drugs. So again, this is first line, a Camprosate or Campril, and then naltrexone. And you'll see that this name naltrexone is going to come back up in opioid treatment as well. So those are just some other anti-craving drugs. And then second line, when all those other ones aren't working, you can try Lamictal. You see here that this is really effective with bipolar and schizophrenia. Most folks, are not going to be on this medication. They're going to do these prior to going to Lamictal. Lamictal is much stronger. Let's jump into opioid dependence. So you've heard of methadone and you've heard of buprenorphine and naltrexone. And so these are substances used for opioid dependence. And so there's a lot of difference between methadone and buprenorphine. And I don't have enough time to go into them, but one essentially mimics the substance. And so this is that agonist, antagonist, those words that we talked about. Methadone can mimic the substance and can sort of block the effects of it. It can block the opiate receptor, but it can be pretty nasty. And so a methadone withdrawal and folks who are taking methadone and are not monitored on methadone pretty regularly, this can be a pretty nasty substance. Methadone withdrawal is pretty rough. Most people say they just would rather do heroin than methadone and go through that withdrawal. But we still use methadone. Buprenorphine, so now we're talking about Suboxone and Subutex, and then of course just buprenorphine, the generic name. So this is a partial agonist. So it partially blocks that receptor site, and is much cleaner. It can handle the withdrawals and the cravings of the opiate. It's just a much cleaner substance. I have worked with people on this substance who have been on this medication for years and years and years, and sound, as you and I do right now, and look as you and I do right now, and you would never know. And it's a pretty. I'm a big fan of this substance when it's monitored properly by a psychiatrist. When it's not, you can get into some problems. Naltrexone does something similar as buprenorphine. These are just different types of substances. So this is just a different class or different category. And one of them, you can see Vivitrol is an injectable, so they get it once a month, and that's kind of nice. Real quick, we'll end. These are alternative medications, and I encourage some of you guys to use ayahuasca for your alternative approach to treatment, but none of you guys did. That's pretty surprising to me. But these are, yeah, alternative meds. Usually you get them from indigenous folks.